everything looks great.
Perfect. I apologize in advance again for the interactiveness, but today we're going to be talking about odds ratios, which is a pretty dry topic. So I'll try to make this as fun as possible. This is a continuation of our evidence-based medicine discussions. So I know statistics can be pretty dry, but odds ratio comes up all the time in research papers and even the news. Being able to interpret them will allow you to be a better clinician, make better clinical decisions, help you communicate this information, especially regarding risk factors associated with the disease processes we treat. And I know that most of you, or all of you guys at this point, have taken STEP and COMLEX exams that have had odds ratios on it. And so I'm hoping that this is going to be a good review for you guys, and especially for those who are still waiting to take step 3 and level 3. I know that Dr. Osorio and Rafa shared this article with you. This is the article I'll be using to discuss odds ratio. It's risk factors for early onset colorectal cancer. I know that not everybody wants to go into gastroenterology, but this topic will be, it's also been in the news over the last couple of years with our high profile famous people who have died from colorectal cancer early on, like our favorite superhero, Black Panther. And I know it's important to keep in mind when we're assessing our patients in the clinics especially, and I know that you'll be asked about it a lot by your patients and your family members and friends who love that free medical advice. So why do we care? Colorectal cancer is the 4th leading cause of cancer in the United States, and it's the 2nd leading cause of colorectal cancer. It's the 2nd leading cause of death in the United States, which you can see in the right image. I don't know if you can see my cursor. And the annual rates, though, of both new cases and deaths are decreasing. This has been going on since the 1980s, and it's likely due to the fact that more people are being screened, but also the changing lifestyle related risk factors. So while the patients who are in that 50 above group have seen decreases in the deaths as well as the incidence, we have seen this rise in cases of patients that are 20 to 49. It's been an increase by about 50%. The reason for this is unknown. It might be due to increasing body weights in this population earlier on, maybe due to the low activity, like physical activity, increasing diabetes, other risk factors such as race and ethnicity might also play a role in it. And in this younger group, most of the colorectal cancers are left-sided, and most of them do have symptoms when they're first presenting, such as bleeding and abdominal pain. And unfortunately, when this group does present, oftentimes it's presenting late stage and with very poor prognosis. So how would you design a study where we're trying to look at patients with early onset colorectal cancer and identify which risk factors are associated with it? So first, this is our first interactive part. In general, what are our options for general study designs that we might want to do in any study? Just, you can list them out, you can say them out loud.
Do like a cohort study.
Mm-hmm. And now I'm going to pick on you a little bit. So what would a cohort study, like what does that usually entail?
So you take a group of individuals and you start monitoring them from baseline. You follow them longitudinally over a period of time. And so it's a type of prospective study design. And, you know, it's appropriate to answer, you know, specific questions. You know, does an exposure increase someone's risk of something is one of them. And so I think.
Mm-hmm. That's great. And one of the only things is for that, it's not great necessarily if it's a rare case as well. That's when you probably wouldn't do a cohort study because it's less likely that the disease will come up. I see anybody else? There's a couple of others, case studies.
Yeah, so Dio left a comment in the chat. I don't know if that's what you were reading, but yeah, case studies, cohort studies, observational studies is what he mentioned.
Yeah. Okay, so I can just move forward also. So besides cohort studies, we have the randomized controlled studies where, you know, patients are randomly put into either the control or the treatment arm, and you'll follow them forward. But for this, you wouldn't want to, you're not really testing for harmful exposures in this, but it could shine light on adverse effects. So it wouldn't necessarily be good in this case. We talked about cohort studies. Case control studies is a retrospective study when we look at, we're interested in an outcome that's very rare or takes a long time to develop, that cohort studies wouldn't be feasible. And we can oftentimes match them, a case and a control, by age, sex, concomitant medical outcomes. And then we have cross-sectionals, which is our snapshot, as they all say on the board exams. And this looks like at data in a point of time, gives us oftentimes the prevalence of the disease. So here for us, we want to basically see what exposures may be associated with those who have developed early onset colorectal cancer. So which of the studies that I described would probably be the best for this? You could write it in the chat.
I think,
Bruno?
I think it would be a cohort, either preferentially prospective, but in real life, it would be easier to do a retrospective.
Mm-hmm.
Like a case control.
Yeah, so Nadim is right. It would be a case control because we have the outcome, the disease state is colorectal cancer, and we want to see the risk factors. So cohort, you start with the exposures, and then you want to see if the disease process comes about. But I mean, it's just how you approach the discussion and what your question is. Either way, you can set up a study that would be a cohort study.
Emily, I like that one statement, just for, again, everybody just be mindful, what's your clinical question? And that's where you decide which design you want. Mm-hmm. And, you know, is it that you're looking for exposures beforehand or you already have it? So again, the clinical question decides your study design. That's why you have to start first with the clinical question before you even move forward to like deciding how you're going to design your study to be able to answer that question, you know, what data to collect, things like that. Okay, go ahead, Emily.
No, absolutely. That's and that's something also to keep in mind in a lot of these questions that you get that come up. So we're going to talk a little bit about the study, how it was designed that we're going to be talking about, and then we'll go into a lot of detail about odds ratios and picking that apart, especially using the study as an example. So this study, what they did, it's a retrospective cohort study. They looked at veterans, and this was veterans from the VA, specifically ages 18 to 49, who underwent a colonoscopy from 1999 to 2014. It's important to keep in mind that this range in time was before we had the screening that we screened for patients for colorectal cancer that were 45 and above. So that's new in the last couple of years. Anyone who had a prior history of colorectal cancer more than 6 months before the baseline screening colonoscopy were excluded from the study, and then anybody who had IBD was also excluded from the study because they have increased risk factors for colorectal cancer. So the cases were selected. They were early onset colorectal cancer cases from the VA. They got this from a cancer registry. They had to have developed colorectal cancer within 6 months of the baseline. And they that population, they got some specific data from them based off of the SIR program. So this allows you to take information about staging, about additionally, they did get histology as well. And just so that you can see kind of the things that were collected for this group, it allows you to see the cancer site specifically, stages, localized, regional, distant, and then these are the specific histology. They only want to look at adenocarcinoma though as well. And then the controls were veterans who had a colonoscopy, but it was normal at baseline. So they also needed to make sure that there was no colon cancer before the colonoscopy was done, no colon cancer within 3 years following. And when they did the colonoscopy, there was no pathology that was even taken. So it had to be totally normal. So predicting variables. When you guys are designing your own research studies, you have to come up with a few risks that you would be interested in looking at specifically. So if you guys can name a few variables that you might be interested in this population, looking at as a risk for early onset colorectal cancer.
Like family history.
Okay.
Smoking history.
Mm-hmm.
IBD.
IBD. Well, so we actually just controlled for, we just said that anybody who had IBD would be excluded. So we won't do that one.
And then age, sex,
Race.
Yeah. So all of the ones that you guys said, family history was taken note of later on, but these are the basic ones that they looked at. Age, sex, race, ethnicity, BMI. They did something interesting with the weight specifically that we'll get into as well, diabetes and aspirin use and smoking. So statistical analysis, this is the meat and potatoes of this. So each candidate's risk factors were described using means and frequencies, and then different analyses were done as well. So for descriptive analysis, what test would you normally do for a descriptive analysis of categorical variables?
Frequencies and proportions.
Okay, so we talked about, yeah, means and frequencies, but what would be like a statistic besides that, like a, I don't know the best way to ask it.
Like a chi-square?
Yeah, perfect, chi-square. And then what about for continuous variables between cases and controls?
Like a t-test?
Yeah, and one more. What would you do if a t-test, so t-tests are only for 2 variables. What if you had more than 2 variables?
Oh, you could do like
ANOVA.
Yeah, ANOVA, perfect. Sorry, I'm totally just like pimping you guys, I know. So then they did univariate as well. And so what would you do to assess, look at the associations of each candidate's risk factors? I guess I kind of ruined it with saying odds, or, but in a case control study, what would you normally do?
Just said she ruined it by saying odds. So
Yes, so it's odds ratio here. You have to, again, this comes up all the time, is in case control studies, you do odds ratios versus cohort studies, you're doing relative risks, and we'll go into why that is. And then they did this with the corresponding confidence interval of 95%. And then they also did multivariate regressions, which allowed them to assess and control for multiple risk factors. They did that from whatever was significant from this univariate analysis. It went into the multivariate analysis. And then they did model fit tests. So I'm not going to go into too much because this is not a lecture about logistic regressions, but model fit tests kind of explains what it is in the name. You want to see if the data fits the models, and from that, from these tests, you'll get p-values. If the p-value is small and then it's significant, it's actually a poor fit. And when it's larger, it would be a better fit. And then, so this is one of the ways that I found pretty useful in remembering, just like a quick way to remember. The odds ratio goes with case controls. You have the vowels are different and odds ratio OR is different. And for cohort, these are two of the same, oh no. So relative risks would go with it. So for them as well, they, like I said, they did something interesting with the weight. They didn't want to necessarily purely look at BMI. They wanted to look at the weight trends over the 10 years before the baseline colonoscopy and how it changed. And then they further characterized it in based off of if they lost 5 kilograms versus if they lost 10 kilograms in the 5 years before. And they did a logistical regression to determine the odds of developing early onset colorectal cancer based off of the weight changes. And then they also did post-hoc analyses. And can somebody just explain what are the benefits of doing a post-hoc analysis? You don't know, that's okay. Okay, I'll take that silence as you don't know. But so post-hoc analyses are when ANOVA tells us basically that the group means are significantly different from each other, but it doesn't tell us which of the means, which of them are significantly different from each other. So you're comparing a bunch of different variables within it, controlling, and then you want to see which specific interactions are significant. So what they did was they used post-hoc analyses to examine the population risk factors for different ages, less than 40 and greater than 40. And remember, the greater than 40 is only 40 to 49. And they assessed also indications for colonoscopies, but they did it with a smaller group. So they took their own little sample of 100 cases and 100 controls, because this required them to go more into chart checking. So they didn't want to do that for the large population that they had. And they also used this smaller sample to look at the family history. So these are some of the risk factors that we mentioned earlier on that we would want to look into. And then they used the Fisher's exact test when they were looking at sample sizes that were too small to run chi-squared. So when the expected value is less than 5, you can't use chi-square, so you have to use this Fisher exact test. And their statistical significance was a p-value of less than, oh, it should be 0.05. 0.5 is very large, sorry for the typo. So let's get into odds ratios. Odds and odds ratios are related to the chances of a binary outcome, something that is present or absent. It's important to note that odds are not the same as probability, where probability is the likelihood of the outcome occurring over all possible outcomes. Odds are the likelihood of outcomes occurring over the likelihood that the outcome doesn't occur. So that's kind of confusing when you think of it in terms of words, as most of this is. So let's discuss it in like terms of rolling a dice, for example. So when you roll a dice, you want to look at the probability of rolling a 4. So the probability of rolling a 4 would be 1 in 6, because 6 is all of the possibilities, all of the outcomes that could be possible. But the odds of rolling a 4 would be 1 in 5, because you're kind of taking out 4 from that bottom number. It's the chances of rolling a 4 over the chances that you roll anything other than a 4. And then odds ratio is just the odds of randomly selecting a study subject that is exposed, given the subject is a case specifically, divided by the odds of randomly selecting a study subject that, did I say that wrong? Randomly selecting a study subject that was exposed, given that the subject is a control. So it should be was not exposed. I apologize, I missed that as well. And so this just goes over what the equation would look like. So it would be A divided by B. So the exposed case divided by exposed control, and that would be all over the non-exposed case divided by the non-exposed control. So like I was saying, this should be non-exposed. I apologize for that. So here's basically my question for you is, what's another way to say odds ratio based off of this? So what are the odds that the exposed is associated with the case compared to those non-exposed?
A times D over C times B.
Yes. So you're saying 4, you're saying 3? Yeah, so it would be 3. It's just rearranging it all. They can ask you in any situation, any question, these questions, and sometimes when you're doing the math like faster, it's easier to just do multiplication on a calculator than dividing a million times. So odds ratios are used to compare the relative odds of the occurrence of an outcome of interest. So we would be looking at a disease or a disorder given the exposure of a variable of interest. So this would be health characteristics, aspects of medical history, and the odds ratio can be used to determine whether a particular exposure is a risk factor for a particular outcome. And it's then used to compare the magnitude of various risk factors for that outcome. So we would use it to test, for example, if male is more likely to be, if being a male is more likely than someone who is not a male to experience colorectal cancer. In the cases of our research question, would be there, and is there an association between the experimental variable and the disease? So here it goes over what the null hypothesis would be. A null hypothesis would be that the odds ratio would be equal to 1, and the alternative hypothesis would be that it's not equal to 1. So this is important to keep in mind, specifically when it comes to this portion of it, because when the odds ratio is equal to 1, like I said, it would be the null hypothesis. The exposure does not affect the odds of the outcome. And when the odds ratio is greater than 1, the exposure is associated, but it's also associated with the higher odds of the outcome occurring. And when the odds ratio is less than 1, the exposure is associated still, but it's associated with a lower outcome, a lower odds of the outcome occurring. And then when we typically do odds ratios, we oftentimes do it with a 95% confidence interval. And if it does not include 1, then it would be statistically significant at the level of 5%. So this will also be important to keep in mind. Okay, little breather for a second before we get into a lot more interaction. Anybody have any questions at this time? Okay, I'm just gonna move on then. So why can't you calculate relative risk from case control studies? Anybody have any idea? No, that's okay. So in cohort studies, we're looking at prospective studies with a fixed number of people that you define. This is kind of what we were describing before. And versus case control studies, case control studies, you're also, we're sampling a group of people who had the outcome and who don't, and we are selecting the cases and the controls. We don't have the sample, we don't have to sample the same number of cases and controls when we're looking retrospectively, but when you're looking prospectively, the cases and controls randomly appear, or the cases would randomly appear. And so we couldn't really select, we could really select just like any number for the sample and it would change the calculations for the risks. So just because we hadn't gone over what the risk ratio calculation would be, it would be A over A plus B. So it includes the total, and C over C plus D. Whereas what we were saying for odds ratio, it's A over B over C over D. And so here we calculate odds ratios. We could do it, like I said, with A over B over C over D, or it could also be A divided by C over B divided by D. And this gives us the totals of our cases and controls, which makes it it makes it internally consistent of a ratio. So that wouldn't be the case if you did it for the relative risk. It wouldn't be internally consistent because we'd be looking at these totals, which are the exposure totals. Okay, so for this, I'm going to let you guys do some calculating. And if you guys can tell me what the odds of being a male would be and having early onset colorectal cancer, the odds of being female with colorectal, early onset colorectal, the odds ratio, and then what this means in context as well. I know I'm not giving you like the confidence intervals, but let's say that it would be significant confidence intervals. So what's the odds of males having early onset colorectal cancer from this?
Should we do it and just give you the answer?
Yeah, you can put the answers in the chat. Okay, I'll give you guys a couple more seconds. Anybody have any answers for it?
Free to use calculators as well. If not, it might be easy as well, Emily, if maybe you walk us through like one of the first examples and then we have people do the other one.
Yeah, that's what I was gonna say. You can also just even put the numbers of how you would calculate it.
Yeah, so I can go through the first one for the odds. So the odds of males having early onset colorectal cancer would be male cases over the normal colonoscopy controls. And so that gives us 0.01.
And I think it looks a little bit intimidating when you see a lot of like really big numbers. I think we have to remember like the example that Emily gave, you know, the odds of like one number in a dice, you know, like, oh yeah, like what are the odds of, if you have like 6 probabilities there and you're choosing only for one number, like the odds of it happening, it's like 1, and like the odds of it not happening are 5. So it's like 1/5. And here, like you have to keep in mind, like you're talking about the whole sample, what are the odds of it having it and what are the odds of it not having it? And you can see like here, like the division for like the males 594 is just like over 55,399, and you're encompassing all the possibilities within the male group, which is what she is asking. I don't know if that made a little bit of sense, but that's how I like to think of it.
Mm-hmm. And then so the odds then of females, yeah, good. I like Nadim's putting it up as well. And so it would be 0.005 would be the odds of them having early onset colorectal cancer. Again, you're looking just at the cases over the normal controls within the female group. And then here we're looking at the odds ratio. I guess I didn't specify specifically what the odds ratio in context of, because so here they're doing it in terms of the odds of males being associated. So, and so, yeah, Nadim, he did the right calculations. And so it's about 2.2 would be the odds. And so what does that mean in context? So yeah, we could do these calculations, but what does this mean based off of this example? So it would mean, oh, you want to go ahead?
Yeah, it means that, males are 2.2 times more likely to develop colorectal cancer compared to females.
Yeah, perfect. And so you can see that below. This would be the results that they showed with that, the exact numbers as well. And here it's about 2.2, and it's significant within this confidence interval as well, because you don't see 1 in the middle of it. And then when you're looking at tables in research articles, whenever it says reference, that means that they're looking specifically at the risk of the other thing in compared to female. So this is the compared to. And like we were saying, it's a positive association, and this is not causation. It's just purely association. We can't do causation with odds ratios or even these prospective and these retrospective studies. So let's just discuss a little bit about what confidence intervals are. So it's the mean of your sample plus or minus the margin of error. So in these calculations, it would be this portion is the margin of error, and these are the means of our sample specifically. And our margin of error tells us how many percentage points your result will differ from the real population value. So the population mean is what you use for continuous values, and the population proportion is what you use for binary categorical. You'll never have to do these calculations. I'm purely just showing it to you for the purpose of understanding how confidence intervals change based off of some of the values that we have in our study and our population. So you'll see, let's just go over the population mean on the right here. So the top is the standard deviation, and the bottom n is the number in the population. So it will change based off of that. So as the standard deviation increases, then the confidence interval will also increase. And so it increases, it also increases. And then as the number of people in the study increases, the confidence interval will decrease. And so this is important because it kind of explains the precision of the study as well. So a large confidence interval will have a low level of precision, whereas a small confidence interval will have a higher level of precision. And so you can see and kind of compare it here. So just as an example, these values are very close to each other. So the confidence interval shows that the means are very close to each other when it comes to age and its high level of precision, whereas the values for this differ more significantly, more widely, and the confidence interval is wider, so it's not as much precision. So, like I mentioned before, odds are not probabilities, and it's important to keep that in mind. There are instances, though, when odds ratios may approximate the relative risk ratios, and not sure if anybody knows when that would be, but I kind of put that out there already. When the outcomes are rare, odds ratios may approximate the relative risks, but when the outcomes are not rare, they always overestimate the relative risk. And so also odds ratios cannot be directly calculated from the relative risks. Lastly, also the odds ratios cannot be, like I said, so they can't be calculated, but they also have a large magnitude when the probability is low. So what does that mean? An example would be a patient who has, let's say, like sleep apnea and weight gain. Let's say that a 20-pound weight increase was shown to increase the odds of developing sleep apnea by a factor of 4. But this is regardless of the starting weight. So we can speculate that the probability of having apnea is though lower in patients who start at a lower body weight, even though the odds are saying it's 4 times greater. So it's kind of confusing then to compare odds ratios and relative risks. This is an example kind of showing in both the both here and here, the relative risks would be the same. And again, doing the calculations for relative risks, you do 2 divided by the total of 100. And so this would be 0.2, sorry. And then the cases would be 40 over 100. This would be 0.02, and the relative risk here would be 0.02 as well. And then, oh, sorry, that's not right. So this is over this. So you do the relative risk would be cases over total over divided by 1 over 100, and that's where you get the relative risk. And then in the bottom, it's 40 over 100 divided by 20 over 100. So that's how you get the 2s. And then for the odds ratios, here you can see that they differ significantly. And that's what I'm saying when the outcomes are rare. So the cases rarely occur. Here it's 2 and 1, then they'll be closer together. But when the cases are more numerous, then they'll be a lot further apart. And this slide just goes over that concept as well, that you can't necessarily equate relative risks with odd ratios. The lines representing the risks of getting the disease, even in the unexposed group. So here's the unexposed group getting the disease. So you would expect it to be less if the outcome is, so when the outcome is very rare, the odds ratio would mimic it here. But as the outcome is less rare, then it would be less likely to be close to the relative risk. Okay, so let's move on to some of the results of the study. I'll try to go through this. I might actually skip through some of this a little bit so that we can move on more towards you guys explaining some of the odds ratios. But here all the subjects, they had 68,000 people as all the subjects, with the cases being 651. So there are very few cases here compared to the normal controls, and most of them were around like 44, 43 years old, and most of them being males. And then this shows the age distribution for early onset colorectal cancer, so most of them falling within that 40 to 49 age range. And most of them were also, so like I said, that most of them were males, and most of them were whites in terms of BMI. Most cases and controls fit within that overweight and obese category.
And for those who ever been at the Veterans Hospital, because that's a lot of the patient population you were seeing, because you know, when you look at the data, you also want to see from 1999 to 2014, this is reflective of the population in the VA, and it is. That's usually what you end up seeing when you're at the Veterans Hospital. There's more gender representation now, but early on it was majority men that you're seeing. But go ahead, Emily.
Yeah, no, absolutely. And it's important to keep this sample in mind when it comes to being able to explain it in terms of other populations. It might not hold true necessarily. And so this does an interesting job of looking at the BMIs, cases and controls. They are very similar, and how they change based off of the stages of cancers. Here they did actually had a pretty good distribution based off of the different stages of cancer. And so this is where we practice our odds ratios. So I want you guys to look at it and tell me, I covered up what the p-values are for it. if you guys can tell me which of these would be significant values just based off of the confidence intervals.
So it's the ones that don't overlap 1.
Mhm.
So age would be significant, sex would be significant. With race and ethnicity, so far all of these are overlapping 1.
Mhm.
For diabetes, that overlaps 1. Smoking status. Some of them are not overlapping 1, which means that like it is significant. Like there's a difference between current smokers are more likely than never smokers to
Mhm.
colorectal cancer, and also, but that's also true for the unknown category and specifically. And then for aspirin use, it's not. It is significant because it doesn't overlap 1. And so actually the use of aspirin is associated with a lower odds of developing colorectal cancer.
Mhm.
BMI as well. It looks like it is significant as well. So, actually, what is the reference for BMI is normal. So actually what's interesting is patients who are overweight are less likely to develop colorectal cancer compared to those that have a normal weight. And the same applies for those who are obese as well.
Yeah, no, those are all very true. And some of these are interesting outcomes that they had, and it's kind of unclear why maybe it's lower weights are less significant here, but they kind of do a good job of hypothesizing that later on. So when you're looking at the p-values here, it goes along exactly with what we're saying with these significant values. Your eye always jumps to the less than 0.001, but keep in mind that here they were using 0.05 as their significance values. Okay, so we're getting there. You guys could answer funny Jeopardy question. When a non-causal association is observed between a given exposure and an outcome is a result of the influence of a third variable. So what is that?
Is that confounding?
Yes, it's confounding. So when we do logistical regression, it's done to kind of eliminate this confounding variables. And it allows us also to estimate the odds ratio while adjusting. So we're adjusting for those confounders. And when we perform logistical regressions, again, this is not a lecture about logistical regressions, the values aren't necessarily interpretable as probabilities, which is why we don't use relative risk here. And we can convert them though to odds ratio. And so when we're looking at the logistical regression to control for multiple variable, the odds ratio for one covariate is consistent for all covariates in the equation. And so here we're kind of discussing an adjusted odds ratio in that sense. And the odds ratio would be for a variable here represents how the odds change with 1 unit increase of that variable holding true for all other variables. And so here you can see kind of the example of how you would convert so in logistical regression, you get the log odds, and then by simple calculation, you can get the odds ratio, which is here. And just simple math again, the log odds can be a positive or a negative, but when you put it back into the equations with exponents, it'll always turn out positive because there's an increased and decreased association based off of 1, not based off of 0. And so the odds ratio for logistical regression is what's always reported, not necessarily the log odds. And So for logistical regression, though, it's important to keep in mind that the odds ratios that you get from the logistical regressions are based off of an arbitrary scale factor. So it makes it really hard to then compare the odds ratios on from other studies. And it's scaled based off of whether or not there are better or more explanatory variables that are added to the model. And so when there are better variables, it changes. So it's really hard to then compare, like I was saying, odds ratios in meta-analyses to each other, because you're not controlling for the same variables in each of the logistical regressions. So you have to keep that in mind. So this is another way to show odds ratios, and I'm gonna let you guys kind of explain it based off of what we know so far, where these bars are the confidence intervals and the dots shows the mean of it, or it shows the odds ratio. So anybody
This is
want
related to the table that Emily already showed before, right, of the variables and how the confidence intervals interact. Just a different representation of it. Can anyone comment on it?
Yeah, so I guess it's like Nadim was saying, if it's you can look at the line as equaling 1, so anything crossing the line has a chance that it's non-significant, whereas anything where the bands aren't crossing the line, like that little dot up in the top right, male gender, you can be fairly confident based on our p-value that it's significant.
Yeah, no, absolutely. And then like it shows down here, if it's above 1, then it's a higher odds of getting early onset colorectal cancer. And if it's below 1, you have a lower risk of, or a lower odds of getting it. So these are just the numbers that go along with the table. But you should be aware of all different representations of how you would look at odds ratios. And this article does a good job of explaining it in all different ways. So the last way that you would explain it is in words. So oftentimes you get all these results and you don't really, putting it into words is a little bit more difficult, or understanding what the words mean can be difficult and confusing. So I will do the first, or I'll do this with you, and hopefully you guys can help me fill in the blanks. So let's start with the first one. For every additional year in age, the odds of developing early onset colorectal cancer increases or decreases. So you guys have to tell me if it's increasing or decreasing based off of this odds ratio, and by what % does it increase or decrease? So yeah, it increases, and by what % does it increase then?
Wait, the answer is there for the first time.
Oh, whoops, sorry, you totally. When I reformatted it, it was all in the same thing. So you get the 5% because it's 0.05 above the 1. So that's how that comes into play. And then for the second one, what is the chance of men developing early onset colorectal cancer? Is it greater than or less than women? And how many times greater than or less than?
It's greater than 8.21 times more likely.
Yeah. So, you know, we just went over based off of percentages. For larger values, you can say 2.2 times greater than women. And then next, for aspirin users, the odds of developing early onset colorectal cancer in aspirin users was what % increased or reduced compared to those of non-aspirin users?
I guess the users had a 34% decreased chance of developing early stage colorectal cancer.
Yeah, so so it's a reduction in it. So Bruno did not fall for the trick when it comes to this. So whereas when it's increased, you look at it just at 0.5 above it, but you also have to do the same when it decreases. You want to see how much below 1 the odds ratio is to explain the percentage. So that's where the 34% came from. And it's a reduction because it's less than 1. And then lastly, we being overweight or obese at the time of colonoscopy compared to normal were both associated with an increase or a decrease, and by what percent?
It would be a
Try?
30.
Or Bruno, sorry. Yeah.
It would be a 31% decrease. Yeah.
So same thing. And then they talk about how they can't really do this with the smoking because it's unknown. And the unknown group, it's just difficult to interpret it. So I don't know that we have crazy amount of time to go over a lot of the other results, but basically what they saw was the weights for both of them, the weight trends for both of them increased at the 10 years before to the 5 years before. You can see it here, but they diverged when during that 5 year before the colonoscopy, where the average weight was significantly lower in early onset colorectal cancer, specifically during that 5 year period. And then this just is comparing the two based off of how much weight was lost. I think that this is not necessarily a great figure to have in context because we're already saying that the weight loss was greater in the early onset colorectal cancer group. So I'm not really sure why we need to compare it here, but they put it there as one of their main figures. And the differences in the weight loss were then significant. And so this is going over another way when they age stratified it based off of, so when they age stratified all of the risk factors. And so they found that overall age was significant, and as well as the males were male with significant odds of increased risk for colorectal cancer. And then we talked about aspirin as well. And then being underweight goes along with the tables that I just showed you before. Being underweight was more likely to be associated with early onset colorectal cancer, but this is only looking at that 5 year period before. So it's basically saying that this is kind of a clue to tell you that they may be getting early onset colorectal cancer. And so that's something to look at in your patients when they're losing weight. We think about cancer oftentimes when they're not intentionally losing weight, whereas being overweight or obese is less likely to be associated with it because you're only looking at that 5 to 10 year period before developing it. Whereas it might have been a better question for them to look at a greater period of time of weight changes, but because this is the VA, we only really have patients that are about 20 years and older, so we don't know what their weights are as children and if they were overweight younger than that. So these are kind of going along with the conclusions that we've been reiterating over and over again, but for the takeaways from this, odds ratios can be explained in a bunch of different ways. I hope I didn't confuse you too much when it came to comparing odds ratios and the relative risks, especially because we didn't have a lecture yet on relative risks. So it's oftentimes confusing discussing something when we don't always know about it. But in terms of just colorectal cancer, here's the plug for us now that most of us are in clinic right now also, is making sure that your patients are being screened for colorectal cancer. This study is done before the guidelines changed for that 45 to 49 group. And like I showed you before, colorectal cancer is a lot more prevalent in this younger age. And if you have patients that have any signs of rectal bleeding, of weight loss as well, then they should be, it wouldn't be a screening test necessarily at that point, and you want to be looking to see if they have colorectal cancer. But because I'm so into GI. I've been looking for this a lot, and I've been catching a lot of our patients in the Ryan Chelsea clinic that have been gone unscreened, or it hasn't been discussed in this age range, or even around the lower 50s. So make sure you're going ahead and doing that, please. All right, any last questions?
And I would just make a comment that that was a recommendation in the last year. And with COVID, I know re-engagement into care, and it's something that I'm mindful as well as a primary care that I do keep it in mind. And I think the other thing that's interesting about the study is, again, it's from 1999 to 2014. And even then, a lot of things were changing, because I still remember the days where a majority of people was, 10 years was what you were told. And it was very few, that everyone was either 10 years and very few were 3 to 5. And now it's known that if specific things are going to be 3 to 5, and then others will be 10 years. But so even just how long you repeated the colonoscopies were changing in that period of time. Or so that's just like, when they were looking at how they were going to define if this was a normal colonoscopy or not. So just kind of thinking in mind of guidelines as well. But I do like your mnemonic regarding the whole odds ratios versus relativism, like how to know which one's which. It's a very complicated, that's why one of the reasons that for me, I like, and this is Rafa's legacy, because I do realize that you guys know that our chiefs have less than 10 days with us. And they're going to graduate, and then the new chiefs are coming. But having said that, the JAMA, EBM, critical appraisal articles are very nice, because what I like is that they don't just give you definitions, but they use it with examples of articles or studies previously. So I learned by patients. So the same thing I learned by actually doing the study or looking at how things were done before with a study. So that's why those articles that are included in the chat, because I know it's already 2:01 and you guys have, but Rafa or Emily, if you guys have any